working with a minor, anybody under the age of 18, you have to get permission from the parents. So come comp time, when you read your little case, if it says, your patient is a 15-year-old female, you better ask mom, i.e. me. I am the stand-in mom. Hey, mom. You know, you can ask, I mean, if they're like 1 or 2 patient identifiers and stuff, are strictly going to go to mom. But say she's 15. You're going to ask her name or date of birth, and you're going to, Mom, is that cool? Yep, that's right. Okay, well, I'm going to be doing this. You know, treat them as they're still your patient, but you still got to check back with mom. Anybody under the age of 18. I know it sounds silly for, like, your teenagers, because what you'll find is parents will probably just drop them off. They're not supposed to do that. But sometimes in the outpatient world, they'll be like, yeah, or they drove themselves if they're, you know, 16 or 17 years old. You still have to make sure there's parental permission. Okay?
So if you have a patient that's 16, you need to tell them beforehand, bring your parent with you?
Yeah, and hopefully the PT has set that up. And in some cases in the outpatient world, after the initial eval, it's an assumed thing. And so they will, like, you know, they're coming after practice or something. They're going to drive themselves or coming after school.
Okay.
So the parent may not always be there, but you just want to double check. You know, even if it's the first time you're seeing them, go back to the PT. Hey, we got parental permission. Are we good? PT's like, yeah, we're good. So if it's younger than that, hopefully the parent's going to stick around. Sadly, you know, at Lakeland Regional, they have a whole pediatric outpatient department, and there were many a parent that, like toddlers and elementary school kids, they would go out and take a smoke or do something and completely leave them. I'm like, I was horrified by that. I'm like, I would never leave my child. You know, I'm going to be like the horrible, like, mother that's going to just always be there. My kids are going to be like 15. They're like, Mom, leave me alone. I'm like, nope, I'm going to be there. But, I mean, that young, they would be like not even in the building. So we had signs everywhere. So you can't leave. And people would still leave. I'm like, that's crazy. That's crazy. So, anyway, the pediatric thing. Okay. So, back to palpation. So, palpating at the shoulder. The manubrium is really easy, and the jugular notch is the top of the manubrium. Everybody okay with that? This little part right here. Manubrium, and that's your jugular notch. Okay? And if you follow that laterally, you run into the sternoclavicular joint. We're going to talk about some ligaments there in a few minutes. And then you keep following that along, and you follow the clavicle all the way out. Oh, here's the other thing about palpating. On the skin, almost always. And there are going to be very few exceptions to that. Pubic symphysis is one. And that's pretty much the only one I can think about. Iliopsoas better be on the skin.
Yeah. Okay.
Yep. Iliopsoas is. Piriformis is. It is. You were good because I guarantee you, it's like piriformis. What if you had to ultrasound that? You can't ultrasound through clothes. You don't feel what you need to feel if you're not feeling on the skin. So the only exception I have to that is the pubic symphysis. And the high adductor muscles when we get there. Like the pectineus, the way high muscles.
I was going to say, what if we get the pectoralis major and we're going with...
You can still get right here. And then you can get right here. And I don't need to be on breast tissue, and I can still palpate.
The gluteus maximus, just want to slide our hand up the door. Okay.
Yeah.
Just making sure.
It's important. It matters.
I understand.
You have an athlete that has a high hamstring strain, and they maybe avulse their ischial tuberosity. You better be up in there making sure what's going on. I wouldn't use that verbiage with your patient, but it's kind of the point.
Get up in here today.
Well, with athletes, you can totally do that because they don't care. And with your older patients, some older people have like no modesty whatsoever. I had a older gentleman who I was working on his hip. I don't even remember what it was. I just remember it was his hip. And so I'm like, okay, Mr. James, we're going to work with your hip today. In the middle of an open outpatient gym with lots of other people around. He's like, all right. He just drops his drawers. I'm like, okay, not necessary. He's like, oh, I thought you need to get to my hip. I'm like, I do, but we don't need to do that in the middle of this gym. He's like, oh, okay. I was like, oh, Lord. So on the skin, you will fail a comp if you palpate through the clothes. Okay. So drape appropriately if you need to. That becomes more of an issue when we get kind of down in here. Up in here, if you're in tank tops, or if guys don't mind, I'll ask the guys, are you comfortable with taking your shirt off? If they say yes, I'm fine with that. For your ladies, you all should be in tank tops. You can work around that. Sport bras, tank tops. You're good. Very cool. And guys, if you have a problem with taking your shirt off, you're welcome to say no. Then you just gotta work around it. Like, I want to see and feel what I'm doing. So if I can see it, that's helpful too. Okay? So clavicle all the way out to the acromion process. And then I can follow the acromion process all the way around. Now I'm going to have a flip. And I'm going to switch sides. I was on the left side, now I'm on the right side. Don't get dyslexic when you do prone to supine, because that'll mess you up. I've done it. I've completely treated the wrong side when I had a patient flip. And they let me do it! And then they're like, oh, that feels really good when it's the other side. I'm like, so, we are all human, we make mistakes, but that is, if you treat the wrong side in a comp, you will see me again. Okay, so acromion process. Do not underestimate the size of the acromion process. And hopefully my washable markers are still in there. If you're having trouble finding it, draw it. It'll wash off, as long as it washes off before the comp. Hope you all take a shower between now and next Friday. Don't underestimate the size of the acromion. It's a lot bigger than most people think it is. Okay? And then you follow it along, and it becomes the spine and the scapula. And that gets me to the vertebral border. Now, with some people, I'll kind of move their arm to help me out with finding their scapula. Yours is pretty easy, so I don't have to move her too much. And then I can follow the vertebral border up to the superior border, and then down to the inferior ankle, and then all the way over to the axillary border until I lose it in her axilla, which then becomes your glenoid. Okay. So I pretty much copied the entire scapula. Okay. The only thing I forgot on the other side was coracoid process. Flip back over. Coracoid process, I think people get confused with the greater tubercle. You got to get off that and get down into the coracoid process. So what I do is I like to come off the top of the clavicle and come down. Some people like to come off of the greater tubercle. Whatever works for you, just make sure you're not. Some people I think get confused on greater lesser tubercle depending on the position of the arm, and they think they're on the coracoid process and they're not. They're in close proximity, but that's not it. So I'll kind of come down off of the clavicle, and in most people it's pretty deep. You gotta go looking for it. Right there. And if she makes that face, you're pretty sure you're on it.
Yeah. Still there. You're still there.
She's like, please let go. Okay? So, sternoclavicular joint, manubrium, you can get all the way down the sternum to xiphoid process. If I was doing xiphoid process, I would go this way. And then I would do sternum this way. Kind of neat, if I needed to. For a comp, if you got sternum, you could go, it's right here. I'm good with that. Okay. Xiphoid process, I would probably go this way. And then manubrium, obviously, is up here. That's the easy one. Okay. Jugular notch, sternoclavicular joint, acromioclavicular joint, where the clavicle meets the acromion. And then there's some corticoclavicular ligaments and some AC ligaments and CC ligaments we're going to talk about here in a minute, but that's the bone piece. Any questions? Clavicle, sternum, scapula. Okay, let's take a quick couple minutes, partner up, make sure you got all those palpations.